this is Manita Chaum. I'm a second-year resident at Cedars Sinai Medical Center in Los Angeles, California. Today, I'll be presenting an interesting case on how a mimicker stays camouflaged, a case of HPV-associated Sinonasal carcinoma, and my faculty mentor is Dr. Horacio Maluf. The outline of my talk consists of the clinical history, the differential diagnoses, the morphologies, and then a summary. For clinical history, this is from a 65-year-old male with past medical history of coronary artery disease. He had a stent put in. He has HIV, on heart therapy, hypertension, hyperlipidemia, and N3. He presented with several months of epistaxis and an enlarging ill-defined mass in his left nasal cavity. He's allergic to sulfa. There's no family history of head and neck cancer. For social history, he's a former smoker, 5-pack year. He quit in 1995. For alcohol, he drinks 1 glass of wine per day. On physical exam, head and neck, there's no visible nasal masses identified. However, his CT sinus without contrast showed an ill-defined polypoid mass measuring about 4 centimeters in greatest dimension in his left nasal cavity, and it completely opacifies his middle and inferior terminates. The patient then underwent an elective endoscopic surgery, and this is what is shown on the resection specimen. On low power, we are able to appreciate globules of hyperchromatic basaloid cells on a background of hyalinostroma with some admixed bluish basal lamina material and foci of cystic spaces. Here's a higher power highlighting the dual cell population. On the lower right, we have the basaloid cell population, and the upper left, the cells are more pleomorphic with atypical mitoses and vacuolated cytoplasm. This is a low power showing the anaplastic giant cells admixed with the basaloid cell population. Here's the higher power of the anaplastic giant cells. These cells look very bizarre, very pleomorphic. On this slide, I just wanted to highlight the dysplastic squamous epithelium that's overlying the tumor. P16 is positive top to bottom, basically in block-like positivity in the squamous epithelium and the underlying tumor. P40 is non-diffuse with areas of myepithelial cell differentiation in the periphery of the nest. You can see those in the upper right hand corner. There is evidence of biphasic myepithelial and ductal cell differentiation as evidenced by SMA and AE13 respectively. And here are the differential diagnoses we have in mind so far, and I'm going to go through one of them one by one. Our first differential diagnosis is adenoid cystic carcinoma, which is a salivary gland carcinoma. They can grow in a solid, cribriform, or tubular pattern. The entity consists of dual cell population, including the abluminal myepithelial cells and the adluminal ductal cells on a background of hyalinostroma with pseudocysts containing the basal lamina material. CD117 or c-KIT show membranous and cytoplasmic positivity, and greater than 80% of the adenoid cystic carcinoma harbor the MYB and SIB gene rearrangements detectable by either FISH or IHC as shown here. Our second differential is HPV-related multiphenotypic sinonasal carcinoma or HMSC. This is characterized by the overlying dysplastic squamous epithelium that can have variable growth patterns, including the solid growth pattern. In B, we can appreciate the inverted growth pattern with fibrovascular core, cribriform growth pattern imparting the adenoid cystic carcinoma-like appearance, and in D, the tubular growth pattern. And the HMSC usually consists predominantly of the basaloid myepithelial cell population. Next, we have the basaloid squamous cell carcinoma. These are nests or trabecular growths of basaloid hyperchromatic cells. Mitoses and comedial necrosis is common, and P40 would be diffusely positive in this entity due to the squamous differentiation. Our next differential is basal cell adenocarcinoma. These can have different growth patterns as well, including the solid, tubular, membranous patterns. And for the nested solid patterns, we are able to appreciate the central large polygonal cells within the center of the nest, and the peripheral area consists of the small nuclear palisading basaloid cells, and these stain positive for BCL2 and beta-catenin, as highlighted here. Nuts midline carcinoma consists of small to medium-sized cells, very hyperchromatic, with scant cytoplasm and prominent nucleoli. There's foci of abrupt keratinization or squamous differentiation, and there's also a background of inflammatory infiltrates. Nut midline carcinoma IHC reveal diffuse speckled nuclear staining. Next in line is the INI1 SMARCB1 deficient sinonasal carcinoma. These are nests of undifferentiated cells on a background of desmoplastic stroma with non-specific area of cytoplasmic vacuosal clearing. The respiratory epithelium can be completely replaced by the neoplastic cells in a pagetoid fashion, and they can have either sheets or very little rhabdoid cell differentiation within the entity itself. SMARCB1 protein IHC will be lost within the tumor nest, but it can stain positive in the endothelial cells, lymphocytes, or the stromal cells. And last but not least, we have EBV-Associated nasopharyngeal carcinoma. These are non-keratinizing nasopharyngeal carcinoma, usually arising in the nasopharynx. Patients usually present with cervical lymphadenopathy because of lymph node involvement, and these will stain positive for EBV. At this point, we've narrowed our differential diagnoses down to these 5 entities. We were able to appreciate the basaloid cells, ductal and myopithelial cells by IHC. We didn't see any rhabdoid cells or undifferentiated cells. So at this point, we've also narrowed further down into 2 differentials, and that include HMSC and cystic carcinoma. Since P16 is positive in the underlying tumor and the overlying squamous epithelium, we signed this case out as HMSC. And NUT protein and INI1 proteins can be helpful in teasing out NUT midline and SMARCB1 deficient sinonasal carcinoma. Molecular is helpful in teasing out all these 5 entities, as adenoid cystic carcinoma would harbor MYB and FIB gene rearrangements. NUT midline would show NUT translocation, and SMARCB1 deficient would show deletion of SMARCB1. HMSC generally has an indolent clinical behavior, so surgeries usually suffice, but radiation may be required if the margin status is unknown or positive, whereas the other 4 entities are more aggressive, so radical excision and chemoradiation may be warranted. The case was signed out as HPV-related multiphenotypic sinonasal carcinoma. It's previously known as HPV-related carcinoma with adenoid cystic carcinoma-like features. HPV-ish probe was negative at this point, so we turned to HPV-16-18 PCR molecular testing, and they were also negative, but it was positive for other high-risk types. And we further genotyped this HPV, and it showed HPV-56 positivity, which is negative in the HPV-ish probe, explaining why it was initially negative in the ish probe results. So what is HPV-related multiphenotypic sinonasal carcinoma? And this is my attempt in integrating this entity, HMSC, into the title of my talk because it does mimic a lot of different neoplasms. Before going into HMSC, I just wanted to touch on briefly on the anatomy of the head and neck. So most HPV-positive head and neck carcinomas arise from the oropharynx, and with the sinonasal tract now recognized as another anatomical hotspot for HPV-related neoplasms. And in the nasopharynx is where the EBV-associated nasopharyngeal carcinoma usually arise from. On the right, I have a table comparing and contrasting the differences between oropharyngeal squamous cell carcinoma and HMSC. So in addition to the differences in location and morphology, these tumors differ in patient demographics as well. For example, HMSC may be seen in a broader age range with a female preponderance. The most commonly associated HPV subtype is type 33 for HMSC, whereas it's type 16 for oropharyngeal squamous cell carcinoma. Both entities have favorable outcome, but cervical lymph nodes metastasis is common in oropharyngeal squamous cell carcinoma, whereas none have been recorded for HMSC. This all started in 2013, where Dr. Bishop at Hopkins at the time did a large and comprehensive HPV analysis on head and neck cancer cases, and he found that 8 cases had features of salivary glands carcinoma, meaning they had both the myopithelial cells and ductal cell differentiation, and they were previously signed out as adenoid cystic carcinoma. He named the entity as human papillomavirus-related carcinoma with adenoid cystic-like features, and he thought they were peculiar because the morphology and IHC features were reminiscent of the salivary glands carcinoma, and they all have a predilection for the sinonasal tract, and it's most commonly associated with HPV-33. In 2017, Dr. Bishop published another case series, and it's the largest case series yet for HMSC. He also renamed it as HPV-related multiphenotypic cytonasal carcinoma, and he proposed this designation because the morphology spectrum is broader than previously appreciated, hence the term multiphenotypic. It's a good term that encompasses the histologic diversity of this entity. And the adenocystic carcinoma component is a consistent feature, but it's not prevailing. And so the cell of origin for this entity is still unknown, but it could possibly arise from the transitional epithelium between the excretory ducts and the overlying surface epithelium. The overlying squamous dysplasia is suggestive of tumor origin to be at the surface and not of the minor salivary glands origin. All 49 cases were HPV positive, and it's still not known how HPV is transmitted to the sinonasal tract. In 2017, WHO provisionally included this to be a separate tumor entity, and it's associated with HPV, most commonly subtype 33. It has an overlying squamous dysplasia. It's negative for MYB gene fusions, which would otherwise be positive in adenoid cystic carcinoma, and HMSC generally has an indolent clinical behavior. The morphology of HMSC is quite variable. Here I just wanted to highlight the basaloid cells within the HMSC entity that demonstrate variable histologic evidence of myopithelial differentiation in the form of cell spindling, as highlighted in A. In B, there's clear cell changes. In C, there's plasmacytoid appearance. And D, there's an extracellular hyaline matrix deposition. The histologic spectrum of HMSC can be quite broad. For example, in A, there's area of anaplastic giant cells. In B, there's squamous cell in the invasive tumor nest. C, there's epithelial, myopithelial carcinoma-like appearance. And D, there's sarcomatoid differentiation with heterologous cartilaginous formation. Pancytokeratin show dual staining pattern, being darker on the ductal cells and paler on the basaloid cells. P40 component S100 highlights the myopithelial cell differentiation. And these are the photomicrographs highlighting the block-like P16 positivity in both the overlying squamous epithelium and the underlying tumor. HPV-H probes are also positive in both cases. There are about 70 cases published to date. Most of them are associated with HPV-33. The majority of the cases have no evidence of disease after resection and or radiation, but it's also not uncommon for them to have local recurrence. In 2019, there's a paper published from Mass Gen highlighting an aggressive subset of HMSC. So the case presented as a 65-year-old male with nosebleed. He had a large mass in the left nasal cavity. He then underwent resection and adjuvant radiation. However, 23 months after, he developed metastatic pulmonary nodules, and it seems to be resistant to treatment. This is a case documenting the earliest local recurrence of HMSC, and it's HPV-16 positive, which is not very common for HMSC. So the authors suggested that there may be a possible relationship between the odd clinical behavior and the molecular characters, and these could be useful in stratifying patients in the future. The prognosis of HMSC is not known due to the limited number of cases. Same goes for management. There's no consensus treatment guidelines established. The standard of care is surgery plus or minus radiation, depending on the margin status. Whether it's unknown or positive, then the patient may require radiation or chemoradiation. And lifelong clinical surveillance may be warranted, as the shortest local recurrence documented is 23 months, whereas the longest local recurrence is 30 years after disease-free survival. Back to our patients. His nosebleed improved significantly, and given that he had an endoscopic piecemeal resection, he likely has positive margins, so post-op chemoradiation therapy would be required, and then there will be no treatment to the neck since reports to date have suggested essentially no risk of nodal spread. In summary, HMSC is associated with HPV. They may have an overlying squamous dysplasia, fails to demonstrate MYB gene fusions, generally has an indolent clinical behaviors. So the clue to diagnosis is when there's a salivary gland tumor, usually high grade, presents within the sinonasal cavity. And it's important to communicate the significance of this finding to the clinicians, as surgical resection is the standard of care, but patients may require radiation or chemoradiation if the margin status is unknown or positive. And the relationship between HPV subtype and clinical behavior needs to be better delineated, as it may have important implications for patient stratification in the future. And here are my references. I'd like to thank Dr. Malouf on his guidance on this presentation. And thank you for listening.